So we're going to take a look at the pathophysiology behind seizures and the signs and symptoms we can expect with different types of seizures and the reason why people are going to get these different types of seizures. So seizure is generally defined as an abnormal excessive discharge of neurons. When we're looking at the brain, the most common area that we can expect to see a seizure in is either the temporal lobe or the motor cortex. And the reason for that is because our hippocampus lives in our temporal lobe in the medial aspects of the brain. And the hippocampus is usually where we're going to see initiation of a seizure. The hippocampus is most prone to abnormal and excessive discharge of neurons. And in people who end up having epilepsy or having seizures, the hippocampus is most likely the area that's going to be affected, that's going to cause this patient to have seizures. So again, what we're looking at is areas of the brain are all connected by neurons. And when someone has a seizure, it's an abnormal firing of one of these neurons. So if we take a look at our hippocampus and say we'll draw some kind of neuronal projections from our hippocampus, and we'll join them by a neural network. And it's important to remember that most of our neurons and synapses within the brain are formed together by this kind of neural network, or a bunch of basically neurons that connect regions of the brain. So we'll say that we have a neural network that maybe runs through some of these guys here, and that's going to make up its own kind of mesh of neurons. And we'll say that these guys are connected over here, and they go over on to connect to their own types of neuronal network. So we see a tight connection between these three neurons, with a slight connection or bridge here, and then a tighter connection between these two. So if we take a look what's happening on an ECG for these people, or an EEG, sorry, for these people, or an encephalogram rather than a cardiogram, we can break it into a certain number of areas. And we're going to say that this patient is starting to seize, or it's going to have a seizure. And we know that, say, that's going to come from our hippocampus, or it's going to come from centrally down here. So these neurons are going to be the ones that are most likely to be affected. So this guy is going to, say, be the proponent of our seizure. So if we look at what's happening in camera number 1, and again, this is very similar to a ECG. What's happening in the ECG is we may see some wavy lines like this, which are going to indicate seizure. So we know that the main seizure is coming around number 2, or this guy here. But because number 1 is connected in this tight neural network, we start to see seizure activity here as well. And these are important concepts to kind of understand, so we can start realizing why someone may have a full-blown seizure, or they may only have certain localized aspects of seizure. So we look at camera number 2, where the seizure is being generated from. If we look on the ECG, what we see is this sharp electrical activity that's indicating that this patient has abnormal excessive discharge of neurons. And if we look at camera number 3, because the neural network isn't as tight, this may not have as much of an effect. It's kind of the take-home point that we're trying to get across here is that in order for a seizure to affect multiple parts of the brain, it's generally going to have to occur in a part of the brain that's highly connected to other areas. So you may see seizures that are focal in nature, or they only affect a small portion of the brain, or you may see seizure that affects a large area of the brain due to this connectiveness of neurons. So we look at the things that can cause seizure. There's a number of different reasons why one may occur. We can have really one of 3 things. So the first thing we generally look at is an increase in excitation, or an increase in excitability of neurons. So it could be an increase in excitation. We could also have decrease in inhibitory neurotransmitters, or the neurotransmitters that are basically keeping the neuronal activity at bay, or decreasing the amount of excitation that we have. So decrease in inhibition or inhibitory neurotransmitters. Or we can have an alteration in sodium or potassium conductions. And we know that sodium is what's going to allow us to have an action potential, and potassium is generally what causes hyperpolarization, or it causes it to stop. So if we have any abnormality in either of those electrolytes, we can start to see disturbances or problems in terms of neuronal function. So we have an alteration in potassium or sodium conduction. So potassium or sodium conduction disturbance. So we take a look at our brain again and start to think about what these actually mean. We can start to see why each would cause a seizure. So we're looking at increase in excitation. Really what we're looking at is something that's going to increase the excitability of the brain. A lot of times this could be something like trauma or drug use that could cause increase in excitation. So really if we're looking at increase in excitation or excitability, a group of nerves or a group of neurons is going to fire at a higher rate. So things that could cause that: trauma, like we talked about in previous videos, or hemorrhage, that's going to destroy neural tissue. So trauma or destruction of neurons, because neurons contain glutamate, and glutamate is an excitatory neurotransmitter. So if we have destruction of those neurons or trauma to those neurons, destruction of the cell wall and release of glutamate, that can cause an increase in excitability, because now we're flooding those cells with glutamate that's going to cause excitation. We can also see drugs causing an increase in seizure activity, or it may just simply be idiopathic, and the patient may have lesions, or they may be epileptic, or there may not be a known cause for why that patient is going to have that type of seizure. Patients could also have decrease in inhibitory neurotransmitters. And really what that means is if we have a neuronal network, generally we have some neurons that are excitatory, and we have some neurons that are inhibitory. That's going to allow us to coordinate neuronal activity and make sure we don't have a whole bunch of neurons firing at once. So we say those guys are excitatory, and we have other guys that live in here that are inhibitory and release things like GABA, which is an inhibitory neurotransmitter. If we have a reduction, or we have a problem with the neurons that are inhibitory or release our GABA, then we're not going to have as much inhibition. It's going to lead to overactivity or overexcitement, and that can lead to patients having increased excitability in the area. So a decrease in inhibition can lead to an abnormal or excessive discharge of neurons. Finally, the last thing that we talked about that can lead to someone having a seizure is disturbances in sodium and potassium conductance. And if we look at what sodium and potassium does, we know that sodium is going to allow for the peak of our action potential, or allow our action potential to happen. And potassium allows for that kind of hyperpolarization of the membrane, so that we can get back to our resting membrane status, or it takes us lower in terms of membrane electricity. So when we're looking at sodium, if we have increase in sodium conductance, or things that are going to allow for increased sodium conductance, that's going to allow for faster action potentials. So anything that increases sodium conductance is going to lead to increased firing. So that could be simply an increase in sodium concentration alone, or it could be things that are going to increase resting membrane potential or decrease threshold potential. And a lot of the same things that we talked about in terms of tachydysrhythmias and differences in conduction. So things that are going to lead to increased sodium conductance are going to lead to increased firing. If we look at the converse of that, we have things that are going to lead to increased hyperpolarization, decreased hyperpolarization, or decreased ability of potassium to bring this membrane potential down below our threshold potential. So normally what we're seeing is potassium comes in, hyperpolarizes the membrane, and then we need the sodium potassium pump to bring us back to normal so we can have an action potential again. Well, if we're not getting this hyperpolarization, or we're not seeing this hyperpolarization occurs, and say we come much higher or much closer to resting membrane potential, the sodium potassium pump doesn't have as much of a job to do in order to bring us back to resting membrane potential. And again, it's much easier for us to have an action potential. So things that are going to decrease the potassium hyperpolarization are going to cause an increased chance of seizure. So when we're looking at things that can cause that, we can start seeing electrolyte imbalances, things like diabetes and drugs that are going to change our concentration of electrolytes, can lead to patients having seizures. So it's always important when we're looking at a seizure, it's easy to diagnose, or it's easy to understand what the pathophysiology behind a seizure is. It's simply an abnormal excessive discharge of neurons. What becomes challenging is figuring out what the pathophysiology behind that, or what the potential cause of that seizure is. What's causing that person to have this pathological, abnormal, excessive discharge of neurons? So you hear things like acronyms like vitamins that give you an idea of the things, or the differential diagnosis of things that can cause a seizure. So it's not necessarily good enough to understand, okay, yeah, that patient's having a seizure. We need to find out what the cause of it is, and if there's any reversible causes in terms of why that patient is having a seizure. When we're looking at causes of seizure, we can really break them down into basically primary causes, or things that are going to cause seizure on their own. Really, when we're looking at primary causes, it's epilepsy. So epilepsy is one of those things that simply causes people to have seizures. People are generally born with it. It's usually a result of lesions to the brain, and it causes someone to have seizure. Most often, if someone is not epileptic, what we're going to see is a secondary cause of seizure. And that's when I was talking about things like those vitamins, or that acronym for things that can cause a seizure. That's what we're looking at. So it's things that aren't necessarily related to epilepsy, which is a primary cause of seizure. It's seizure as a result of things like trauma, or drug use, or a metabolic condition, or bleeding into the brain. Something else is the pathology, and then as a result of that, seizure is a symptom that that patient is developing. So when we talk about seizures, we can break them down into two different types of seizure. You can have a generalized seizure or a partial seizure. And the first ones we're going to talk about are partial seizures. And we can break down a partial seizure even further into two different types of partial seizure. So in terms of partial seizure, we can have a complex partial seizure, or we can have a simple partial seizure. And basically what they relate to are different areas of brain firing. So when we're looking at differentiating a partial seizure between a generalized seizure, partial seizure only involves a unilateral hemisphere. We're not seeing a generalized discharge of neurons within the brain. It's isolated to a single hemisphere. So this isn't going to be the patient that you see in the grand mal or tonic-clonic seizure. This is a patient who is only having unilateral firing of either an entire or a localized part of the hemisphere, and that's what's causing them to have a seizure. And they generally are challenging to recognize at first because they don't look like the common seizure that everyone's used to seeing. So in a complex partial seizure, what's happening is we have firing that's isolated to the entirety of a hemisphere. So we have an area of the brain that is causing this abnormal excessive discharge, and it's going to result in seizure activity throughout the entirety of this hemisphere. So if we're currently looking at the left hemisphere of the brain, then that's what we're seeing, is we're seeing abnormal seizure activity or abnormal excessive discharge of neurons throughout the entirety of that hemisphere. On the converse to that, when we're looking at a simple partial seizure, what we're seeing is a localized area of discharge. So we'll say it may only be this area of the brain that's involved. So it's isolated to the left hemisphere still, but the entirety of the hemisphere is not involved. We're only seeing one localized area or one small area of the brain being affected. The big difference between these two is that in a complex partial seizure, the patient's going to lose consciousness. So the defining characteristic of a complex partial seizure is the alteration of consciousness. So in complex partial seizure, what we're really seeing is alteration of consciousness. And when we're saying alteration in consciousness, we can really break that down again into two different things that we're looking for in these patients. We're looking for them to have some sort of lack in awareness or having some sort of decrease in responsiveness. So the two ways we usually look at this is if the patient has some sort of amnesia of the event, or they're not able to recall what happened, if the patient has a decreased level of awareness during the seizure, or they're not responding to you during this type of seizure, then we'll define it as a complex partial seizure. If the patient has the signs and symptoms of partial seizure, but they do not have an alteration in consciousness, then that patient is not having a complex partial seizure. It's a simple partial seizure. And when we're looking at simple partial seizures, there's really four main things that we're looking for. We can have motor signs. We can have somatosensory or special sense signs. We can have autonomic symptoms, and we can have psychic symptoms. The important thing to recognize between these two types of seizures is these things like motor signs, somatosensory or special sense signs, autonomic signs, or psychic signs can all be involved in your complex partial seizure. So really, that defining characteristics is simply that alteration in consciousness. These patients may develop motor signs, somatosensory special sense signs, autonomic or psychic signs, especially before the seizure occurs. But it's when they have this alteration in consciousness, or this decreased level of awareness or decreased level of responsiveness, is when the seizure becomes complex in nature. So really, all we're looking for is the presence of these signs or symptoms with or without loss of consciousness in order, or alteration of consciousness in order to determine whether this is complex or partial or not. When we're looking at complex partial seizures, we also see certain things that lead us to believe that we do have this alteration in consciousness or alteration in awareness. And we call these things automatisms. And if you're having a challenging time differentiating whether this person has actually lost awareness or actually lost responsiveness, we can look for things like these automatisms. And people can have different types. We can have things like de novo automatisms, or basically it means they're doing a new task, like lip smacking or biting their lips. So you can see de novo automatisms. We can have reactive automatisms. So you may try to get someone to respond to you, or you may be doing something like putting your hand out, and they may instinctively shake it, but they don't let go. So they react to you, but they're not aware to what they're doing. So we can have reactive automatisms, or we can have preservative automatisms. And preservative automatisms basically mean that, say someone's doing something like washing dishes before they start to have the seizure, they'll continue washing a single dish or putting their hands in the water and making that washing motion, but they are not aware of what they're doing and they're not actually responding to you. So automatisms are generally specific, or they're characteristic of your complex partial seizure. So you see a patient who will generally start with having a simple partial seizure. So you may have a motor sign, a somatosensory sign, autonomic or psychic sign. If it stops there, then that is a simple partial seizure. If the patient goes on to continue to have an alteration of consciousness, you may see automatisms develop. Then that patient's having a complex partial seizure. And the large majority of complex partial seizures are preceded by a simple partial seizure. And that's what we call an aura. So when someone has something like a feeling of deja vu, or they have a strange smell or taste in their mouth, they may hear auditory hallucinations, often people will know that that's a trigger to their seizure. They're having an aura. So when we talk about aura, we're talking about a simple partial seizure, or a localized area of brain dysfunction, or excessive neuronal function that can lead to simply that. So it may stop there and just terminate as a simple partial seizure, or it may lead on to be a complex partial seizure, where the patient has a loss of consciousness or alteration in consciousness, where they're not responding normally, or they have a lack of awareness of what's going on. Now, these seizures normally occur in the temporal lobe, but they can occur in different areas of the brain. So if we look at what's going on, or what types of signs and symptoms we can see in these patients, we can really break them down based on what lobe of the brain is affected. So for patients who have temporal lobe involvement, and again, temporal lobe is the most commonly involved lobe for patients having a partial seizure, we're going to see things like auditory hallucinations. And that makes sense because we know our auditory center lives in the temporal region of the brain. These patients also end up having things like emotional or psychic symptoms. And people describe these as feelings of anger or rage, feelings of deja vu or jamais vu. Deja vu in the sense that they have a feeling that they've done something before. Jamais vu in the sense that people are doing something familiar to them, which feels extremely unfamiliar to them. So again, these patients may be having seizures, but without having the symptoms that people generally associate with a seizure. So people, generally associate that tonic-clonic or shaking movement with a seizure. Well, someone may simply be hallucinating or having emotional disturbance or a psychiatric disturbance in terms of, say, deja vu or jamais vu. And in those cases, we should include seizure as an underlying potential cause. So that would be a partial seizure. If the patient had an altered level of awareness or altered level of responsiveness during these events, then we would classify it as a complex partial seizure. The next most affected area of the brain in terms of partial seizures is the frontal lobe, and most specifically, it's that motor cortex. So we're looking at the motor cortex here. And if you think about the responsibility of this area, what we're going to see is some sort of basically tonic movement of an area of the body. And it's going to be usually contralateral to the location of the seizure. So if we're having a very localized seizure, you may see something like simply tonic movement of the face, tonic movement of the hand or the arm. Or you may see it localized to the entire one side of a body. And again, if this patient's having a simple partial seizure, they won't actually have any loss of consciousness or loss of awareness. You may just see that tonic movement of one area or plane of the body. Again, if it goes into a complex partial seizure, the patient is not necessarily going to be unconscious, but will have some sort of alteration in consciousness. It's important to note for our complex partial seizures that alteration in awareness or responsiveness generally only lasts 30 seconds to 1 minute. So we take a look back at what we were talking about here. That alteration in consciousness is generally only lasting somewhere between 30 seconds and 1 minute. In some cases, it can last as long as 2 minutes. So generally lasting 30 seconds, but it can last anywhere between 1 and 2 minutes. So in terms of partial seizures, we know that the temporal lobe can be involved, and in those cases we usually get things like auditory hallucinations or emotional or psychic symptoms. The frontal lobe or the motor cortex is the next most likely area to be involved, and the frontal lobe can be involved as well. If we do have frontal lobe involvement, you may see things like the patient may be mute because we have damage to our language center. If we have damage to the motor cortex, like we said, you may see tonic movement, contralaterally. And where we see that tonic movement is going to be specific to what area of the brain involved and how much of that area of the brain is involved. And you may also see what's called a Jacksonian march, where the seizure activity actually goes from, say, the hand to the forearm to the bicep, and we see it moving along the body. Other rare or more rare areas that can be involved are places like the parietal lobe. And if we start to see seizure in the parietal lobe, it's where people may get things like vertigo. You may see strange sensations or issues with the special senses. If someone's having a seizure in this area. And then finally, our occipital lobe can be involved. And again, this is very rare. And this is where we see vision disturbance or hallucination. So just to recap, we have two different types of partial seizures that we can have. We have a complex partial seizure and a simple partial seizure. In the complex partial seizure, what's happening is we have abnormal discharge of neurons that's isolated to an entire hemisphere. So generally either the entire right or left hemisphere is going to be involved. As a result of this, we may see signs of simple partial seizures, so things like motor symptoms, somatosensory, autonomic, or psychic symptoms. So the things we talked about, like tonic movement of the face, or we may have strange smells or hallucinations. With these patients, though, the defining characteristic is that they're going to have some sort of alteration of consciousness. So they're going to have a decreased level of awareness or a decreased level of responsiveness. This decrease or alteration in consciousness is often defined by automatisms. So someone starts continuously doing something or is doing something automatically without having any recollection or knowledge that they're doing it. So maybe response to something that you're doing, maybe a new task that they do over and over again, like smacking their lips or swallowing repetitively, or maybe a preservative motion. So say they're stirring a pot before they start having the seizure, they continue to stir that pot aimlessly. But again, the big defining characteristic between that complex partial and simple partial seizure is that alteration in consciousness. And again, that's usually lasting somewhere between 30 seconds and a minute, but could last as long as 2 minutes. Our simple partial seizure is defined by no alteration of consciousness. The patient simply has some sort of motor, somatosensory, special sense, autonomic, or psychic symptom that they are well aware that they're having. So the patient